Welcome back to the Deep Dive. Today we're taking a really close look, a deep dive into the genetics and pathology of Klinefelter syndrome. It's one of the most common sex chromosome disorders, but often missed.
That's right. And we've got a good stack of sources, everything from sort of classic pathology texts to the latest on fertility research. Our mission today really is to unpack that 47,000 XXY blueprint. We want to understand why that extra X chromosome causes such a specific set of features, risks, well, and challenges.
Okay, so let's maybe start with some context. When people hear chromosomal disorder,
Yeah.
they often think of, very severe developmental problems. And yeah, that's often true for the autosomes. The non-sex chromosomes like trisomy 13 or 18, those have very serious consequences. But having extra or missing sex chromosomes, X's or Y's, it seems to be much better tolerated by the body. Why is that? Why is this tolerance sort of fundamental here?
It really is the anchor point for this whole discussion. That tolerance exists because the body has, well, pretty powerful ways to handle extra sex chromosome material. There are basically two big safety valves. The first one is X inactivation, sometimes called lionization.
Right.
In any typical female cell, XX, one X chromosome is essentially switched off, condensed down into what's called a bar body, so it compensates for having two X's.
Okay, so one X gets silenced. What's the second safety valve?
The second one is the Y chromosome itself. It's actually, genetically speaking, quite modest. It carries the crucial SRY gene, which kicks off male development.
The master switch.
Exactly, the master switch. But beyond that, it doesn't carry a huge amount of other genetic information compared to the X or the autosomes. So because of these mechanisms, X and Y chromosome issues usually cause problems that are, let's say, more subtle, often chronic, and mainly related to sexual development and fertility, rather than, major organ malformations seen in autosomal trisomies.
Okay, that makes sense. And it sets us up perfectly for Klinefelter syndrome, KS. We're focusing specifically on individuals with that extra X chromosome, the 47XXY karyotype.
That's the classic definition. Male hypogonadism, meaning underactive tests occurring in someone with two or more X chromosomes and at least one Y, usually 47,000 XXY.
And you mentioned it's common.
It really is. KS is the most common genetic condition involving sex chromosomes, and crucially, it's the most common genetic cause of hypogonadism in males. The cited incidence is around 1 in 660 live male births.
Wow, 1 in 660. That's remarkably frequent for a genetic syndrome.
It is, and our sources really stress that this figure is probably an underestimate.
Why is that?
Because the features can vary so much. Some individuals look almost entirely typical, maybe just a bit tall, while others have the classic textbook signs. So milder cases, they might just never get diagnosed or maybe only discovered much later if they seek help for infertility.
And that variability, I suppose, connects to when it's typically diagnosed. The symptoms aren't usually obvious at birth, right? Even though the genetic makeup is there from conception.
Exactly. It's rarely diagnosed before puberty.
Why the delay?
Because the main features, especially the physical ones and the health risks, are really driven by the hormonal problems, the hypogonadism. And those hormonal issues only become obvious when the body is supposed to go through puberty, through that big hormonal shift in adolescence, and it doesn't happen properly.
So the lack of normal male development, that's the trigger for investigation.
That's usually the flag, yes. Before then, a boy with KS might just seem tall, maybe a bit lanky or uncoordinated.
Yeah.
So the diagnosis for KS, and really for most sex chromosome disorders, often gets delayed until those secondary sexual characteristics fail to appear normally. Early adolescence is really the key time window.
Okay, so the symptoms wait for puberty, but the underlying genetic issue, that 47,000 XXY blueprint, has been there all along. Let's dig into how that extra chromosome actually arises.
Right. So the classic 47,000 XXY karyotype makes up the vast majority, about 90% of cases. And it all stems from a single error during the making of sperm or eggs. It's called nondisjunction.
Nondisjunction. Can you just quickly recap what that means for our listeners?
Sure. Nondisjunction just means that chromosomes fail to separate correctly during cell division. For KS, this happens during meiosis. That's the special type of cell division that creates germ cells, sperm, and eggs. So instead of getting a sperm or egg with just one sex chromosome, an X or a Y, you end up with one that has two, either XX or XY.
And when that abnormal sperm or egg fuses with a normal one.
Exactly. You get the 47,000 XXY zygote. For example, an XX egg fertilized by a normal Y sperm, or a normal X egg fertilized by an XY sperm.
Is the error more common in egg formation or sperm formation?
It's interesting the sources say it's roughly equal. Nondisjunction in the mother's first meiotic division and nondisjunction in the father's first meiotic division are both significant contributors.
In other risk factors, I know maternal age often comes up with nondisjunction.
Yes, advanced maternal age, especially being over 40, is a known risk factor for the egg nondisjunction that can lead to the extra X. It's similar to the risk for Down syndrome, for example. But it's important to remember the clinical syndrome, the KS itself, looks the same regardless of whether the extra X came from the mother or the father.
Okay, you said 90% are the classic 47,000 XXY. What about the other 10–15%? That's where things can get even more variable, right?
That's where we see mosaicism. The most common mosaic pattern is 46XY, 47,000XXY.
Meaning the person has two different cell lines in their body.
Exactly. Some cells are the typical male 46XY, and other cells have the Klinefelter 47,000XXY pattern.
So the proportion and location of those normal cells must really affect how severe the symptoms are.
Absolutely. Someone with a high percentage of normal 46XY cells, especially in key tissues like the testes, might have a very mild version of KS, maybe just infertility without the tall stature or significant hypogonadism. This is where better genetic testing, like high-throughput methods, is really helping. It can pick up these subtle mosaic forms that might be missed otherwise. And the sources also mention rarer, more complex variations too, like structural issues on the X chromosome, which can further complicate things.
Okay, let's move to the clinical picture once puberty starts, or rather fails to start properly. The sources use this term eunuchoid body habitus. What does that actually look like?
Eunuchoid habitus describes a specific pattern of skeletal growth. People with KS are often tall, yes, but the key is disproportionate growth. Specifically, they have an increase in the length from the soles of their feet up to the pubic bone that's called a lower segment length.
So their legs are unusually long compared to their torso.
Precisely. It gives them that elongated look, often narrow shoulders too. If you measure their arm span, it's frequently longer than their height, which is the opposite of the typical male ratio.
Interesting. And you mentioned this links back to the genetics?
Yes, we'll definitely circle back to that when we talk molecular causes. It's tied to a specific gene.
Okay. So that's the body frame. But the really consistent clinical finding, the one that's always present, is related to the reproductive organs.
Yes, the hypogonadism is the absolute central finding. It manifests as small, firm, underdeveloped tests, often described as atrophic.
How small are we talking?
Typically the size you'd see in a prepubertal boy, maybe less than 2 centimeters long. Very small volume. And this often goes along with a small penis, sometimes called a micropenis.
And because these tests aren't functioning properly, the secondary sexual characteristics don't develop either.
Correct, because there's not enough testosterone being produced. So you see sparse or absent facial hair, maybe less body hair overall. The pubic hair doesn't take on the typical male diamond pattern, and the voice often stays higher pitched, doesn't fully deepen. Plus, gynecomastia, breast tissue enlargement, is pretty common, maybe in 30 to 50% of individuals. It can be palpable, sometimes tender.
Okay. What about impacts beyond the physical? How does the extra X affect cognitive development or psychological aspects?
Cognitively, there's quite a range. Generally, IQ scores fall within the normal range, perhaps slightly below average sometimes. Severe intellectual disability is rare with the classic 47,000 XY, though it becomes more likely if there are even more extra X chromosomes, like in 48,000 XXY.
But the sources seem to point to a specific type of cognitive challenge.
They do. There tends to be a modest but noticeable deficit specifically in verbal skills. Difficulties with language comprehension, reading skills, maybe auditory processing. Sometimes issues with expressing complex thoughts or abstract language. This can lead to challenges in school and sometimes social situations. It really highlights the need for early identification and support, like speech therapy.
Any common personality traits mentioned?
The literature often describes a tendency towards shyness, maybe some timidity, or what might seem like emotional immaturity. Supportive behavioral approaches are often helpful.
Right, let's pivot now to the core pathology, the hormonal situation and what's happening inside the testes. You said KS is the major genetic cause of reduced sperm production and infertility. What does the testicular tissue actually look like under the microscope?
Histologically, it's quite striking. The testes show severe atrophy, as we mentioned. The seminiferous tubules, the tiny tubes where sperm are normally made, they undergo this process called hyalinization.
Hyalinization.
It means they get replaced by this dense, pink, glassy, collagenous scar tissue. We sometimes call them ghost tubules. They're essentially non-functional fibrotic remnants.
So the sperm factories are basically shut down and scarred over.
Pretty much entirely. You might find a few scattered areas with very primitive-looking cell cords, like tubules that never fully developed or matured, but no active sperm production in most areas. And this destruction process, it actually starts subtly in childhood, but really accelerates during puberty.
Now, here's something that seems counterintuitive from the sources. The patient is hypogonadal low testosterone, but the Leydig cells, which are the testosterone-producing cells, often look prominent on the slide. How does that work?
Yeah, that's a classic point of confusion. It looks like there are lots of Leydig cells, maybe even hyperplasia, but it's largely an illusion.
An illusion. How so?
Because the seminiferous tubules have shrunk and disappeared, the Leydig cells, which sit in the tissue between the tubules, get crowded together. So relative to the empty space, they appear more numerous or prominent.
Ah, okay. So it's not that each Leydig cell is working overtime, or that there are truly more functional cells. It's just that the surrounding tissue has collapsed, making them look packed together.
Exactly. Their total testosterone output is still low, reflecting the overall testicular failure, even though the pituitary gland is sending strong signals trying to stimulate them. The environment just isn't supportive.
That makes sense. And that leads right into the hormone levels. What does the body do when it senses the testes aren't responding?
The pituitary gland goes into overdrive. It dramatically increases the output of gonadotropins, specifically follicle-stimulating hormone, FSH, and luteinizing hormone, LH.
Why those two?
FSH normally stimulates sperm production in the tubules, and LH normally stimulates testosterone production by the Leydig cells. Since both processes are failing, the pituitary keeps shouting louder, trying to get a response. So, plasma FSH levels are consistently markedly elevated. That's a direct biochemical marker of the severe seminiferous tubule damage. LH levels are also usually high.
And what about the hormones the testes are supposed to be making? Testosterone and estrogen.
Testosterone levels are variably low. They might be in the low normal range, or frankly low, reflecting that Leydig cell failure despite the high LH. But here's the crucial part. Plasma estradiol, the main estrogen, is often elevated.
Elevated estrogen, alongside low testosterone. That explains the feminizing features like gynecomastia. But why is estrogen elevated?
The exact mechanism isn't perfectly clear, but a leading idea relates to body composition. Individuals with KS often have increased body fat, especially around the abdomen's central adiposity. And adipose tissue, fat tissue, contains an enzyme called aromatase. Aromatase converts testosterone into estradiol.
Okay.
So more fat tissue means more aromatase activity, leading to more peripheral conversion of the already limited testosterone into estrogen.
Wow, so it's a kind of vicious cycle.
Okay.
Low testosterone contributes to fat gain. The fat gain then converts more testosterone to estrogen, which further worsens the hormonal imbalance and the feminizing effects.
That's the cycle, yes. And the clinical picture you see in any individual, how much gynecomastia, lack of virilization, it really depends on that ratio between the elevated estrogens and the reduced testosterone. This is why testosterone therapy is so important.
Right. And this hormonal imbalance, the genetic situation, it goes way beyond reproduction. KS has significant long-term health implications, serious systemic comorbidities. What are the big ones we need to be aware of?
Absolutely. It's a multi-system condition. Metabolically, there's a much higher risk of developing type 2 diabetes and metabolic syndrome.
Linked to the hormones again?
Directly linked.
Yeah.
Chronic low testosterone is associated with increased visceral fat, that abdominal fat we mentioned, and that drives insulin resistance.
So testosterone therapy isn't just for looks or libido. It's potentially protective against diabetes.
It's a key part of metabolic management, yes. It helps improve insulin sensitivity, lipid profiles, and body composition, hopefully mitigating that diabetes risk. Then there's cardiovascular health. KS patients have specific vulnerabilities there too. There's a higher risk for certain congenital heart issues.
Like what?
The most common finding in adults is mitral valve prolapse, MVP. It might be present in up to 50% of adult men with KS. They also seem to have a higher rate of things like atrial and ventricular septal defects, holes between the heart chambers. Regular cardiac checkups are important.
And skeletal health. Bones must be affected by the low testosterone too.
Definitely.
Yeah.
Without adequate testosterone and the normal balance with estrogen, bone turnover gets disrupted. This leads to an increased risk of osteoporosis and fractures, often starting much earlier in life than in the general male population. Maintaining bone density is another major goal of hormone therapy.
Okay, now, the really startling risk mentioned in the sources, the malignancy risk. This seems crucial for long-term care.
It is absolutely critical. Patients with Klinefelter syndrome have a dramatically increased risk, the sources say 20 to 30-fold higher, of developing a specific type of cancer, extragonadal germ cell tumors.
20 to 30 times higher, that's huge. And extragonadal means outside the testes.
Exactly. These tumors typically arise in the mediastinum, the central part of the chest cavity.
Why there?
The theory involves germ cell migration during development. Germ cells are the precursors to sperm. Normally, they migrate down to the testes. Sometimes some can get stranded along the midline path, like in the chest. In the context of the 47,000 XXY genetics, these misplaced germ cells seem to be much more prone to turning cancerous later in life, forming teratomas or other germ cell tumors.
That's a serious surveillance issue. Are there other cancer or autoimmune risks?
Yes. There's also an increased risk of breast cancer in men with KS, bringing their risk closer to that of females, which makes sense given the altered estrogen-testosterone ratio. And they also show a higher frequency of certain autoimmune diseases, particularly systemic lupus erythematosus, SLE. This hints that the extra X chromosome, even with inactivation, somehow dysregulates the immune system.
Okay, this brings us to the really fascinating core question. We started by saying the body is good at silencing extra X chromosomes through lionization. So if one X is mostly turned off, why do KS individuals still have all these distinct features, the height, the hypogonadism, the cancer risk? What's going on at the molecular level?
This really is the aha moment, isn't it? It challenges the idea that inactivation is a perfect fix. The key is that X inactivation is incomplete. Estimates vary, but maybe around 15% to even 35% of genes on the X chromosome escape inactivation. They remain active on both X chromosomes in a 47,000 XY individual.
So they get a double dose of those specific escapee genes compared to a 46XY male.
Precisely. And it's this gene dosage imbalance, this overexpression of maybe a few hundred genes, that is thought to drive the entire KS phenotype. It's enough to subtly alter development and function across many systems.
Okay, so it's the genes that don't get silenced that cause the problems.
Yeah.
Can we link specific escapee genes to specific features? You mentioned the height earlier.
Yes, this is a great example. The characteristic tall stature and long legs are strongly linked to a gene called SHOX, which stands for short stature homeobox gene.
SHOX gene, where is it located?
It's in the pseudo-autosomal region of the X chromosome. That means it's in a region that's shared with the Y chromosome, and crucially, it's known to escape X inactivation.
And it's related to growth.
Yes, it's a key regulator of bone growth. So having an extra active copy of SHOX in KS leads to increased cell proliferation in the growth plates, resulting in that taller stature and particularly the longer limbs.
That fits perfectly. And you can see the opposite effect too, right?
Exactly. Look at Turner syndrome, where individuals have only one X chromosome, 45 and a X. They're missing a copy of the SHOX gene, and a primary feature of Turner syndrome is short stature. It's a beautiful demonstration of gene dosage effect.
Okay, SHOX explains the height. But what about the really central problem, the severe hypogonadism, the poor response to androgens? This brings us to what the sources call the androgen receptor paradox. This sounds complicated.
It is fascinating and a bit counterintuitive. Let's break it down. The gene for the androgen receptor, the protein that testosterone binds to, is located on the X chromosome.
Okay.
This gene has a variable region within it, specifically a repeating sequence of 3 DNA bases, CAG. The number of these CAG repeats varies between people, and here's the key. The length of this CAG repeat acts like a sensitivity dial for the receptor. Shorter CAG repeats mean the receptor is more sensitive, more efficient at responding to testosterone. Longer CAG repeats mean the receptor is less sensitive, less efficient. This variation is normal in everyone.
So, ideally, someone with low testosterone, like in KS, would benefit most from having a receptor with a short CAG repeat, the more sensitive version, to make the most of the hormone they do have.
Logically, yes, that would seem beneficial. But here's the twist, the paradox. The body, in its attempt to deal with the extra X chromosome, preferentially inactivates one of the X's. And the evidence suggests that the X chromosome carrying the androgen receptor allele with the shortest, most sensitive CAG repeat is preferentially silenced.
Wait. The body chooses to turn off the better, more sensitive receptor. That sounds like it's making the problem worse.
It does seem like biological self-sabotage, doesn't it? The precise why is complex, maybe related to silencing the generally more transcriptionally active X, but the result is clear and clinically detrimental. The KS individual is left primarily using the androgen receptor coded by the X chromosome with the longer, less sensitive CAG repeats.
So they've got two problems hitting their androgen signaling. First, low levels of testosterone being produced. And second, the testosterone that is there is interacting with receptors that are inherently less responsive.
Exactly. It's a double hit. This dramatically reduces the overall effectiveness of androgen signaling in the body, significantly worsening the hypogonadism that was already present due to testicular failure. It likely contributes directly to things like poor muscle development, the small penis size, the incomplete virilization. It shows that the KS phenotype isn't just about the extra X itself, but also about the body's complex and sometimes flawed attempts to compensate.
Wow. And is the impact just from X-linked genes?
That's another important point. The sources indicate that the effects ripple outwards. Many genes found to be upregulated or downregulated in KS individuals are actually located on the autosomes, not the X chromosome. This suggests the extra X acts more like a global disruptor, subtly tweaking gene expression across the entire genome. It really underscores that this is a systemic gene dosage disorder.
Okay, so that's a deep dive into the complex molecular picture. But medicine isn't static. How is the approach to managing KS evolving? What are the recent updates and advancements?
Well, one of the biggest shifts is towards much earlier diagnosis.
Right, you mentioned NIPT and newborn screening potentially picking it up now.
Exactly. Instead of waiting for puberty to fail, we're increasingly identifying KS prenatally or in infancy.
And why is that so crucial? What difference does finding out at age 1 versus age 14 make?
It's potentially transformative. It allows for proactive monitoring and intervention right from the start. Think about those verbal skills deficits we talked about.
Right.
If you know a child has KS, you can screen for language delays early, maybe start speech therapy in preschool. This can make a huge difference to their academic success and social development long before puberty even begins. It shifts the whole paradigm from reacting to problems to preventing them or lessening their impact. And also, identifying those mosaic cases early with better genetic testing gives a clearer picture of prognosis, especially regarding things like fertility potential.
So early diagnosis is key. What about treatments? Hormone replacement is still central, right?
Hormone replacement therapy, usually testosterone, is still the cornerstone, typically starting around age 11 or 12 to mimic natural puberty. But the way we approach it is becoming much more refined.
How so?
Modern testosterone replacement therapy, or TST, protocols aren't just focused on inducing secondary sex characteristics like beard growth and voice deepening, although those are important for quality of life. There's a much greater emphasis now on optimizing TST to specifically address those long-term health risks we discussed, preserving bone density to prevent osteoporosis, improving metabolic health to reduce diabetes risk, managing fatigue, and potentially improving body composition.
So using physiological doses, maybe long-acting injections or gels to maintain steady levels.
Precisely. The goal is stable, long-term hormonal balance to protect overall health. It's really integrated care now, including regular checks for metabolic issues, bone density scans, and cardiac monitoring, especially for that mitral valve prolapse risk. It's about improving longevity and lifelong well-being.
That makes sense. Now, for many individuals and families, one of the hardest aspects of a KS diagnosis historically was the assumption of complete infertility. Have there been advances there?
This is probably one of the most hopeful areas of advancement. For decades, yes, KS was considered a cause of absolute sterility due to the severe testicular damage. But research found that even in those extensively damaged tests, sometimes small, isolated pockets of active sperm production can persist, tiny islands of spermatogenesis.
Really? Even with all that fibrosis?
Even with that, yes. And a surgical technique called microdissection testicular sperm extraction microtease was developed to try and find these pockets.
Microtease. How does that work?
It's a specialized microsurgical procedure. The surgeon opens the tests and, using a high-powered operating microscope, meticulously examines the seminiferous tubules, looking for any that appear slightly fuller or healthier than the surrounding fibrotic tissue. If they find such areas, they extract tiny samples, hoping to find viable sperm.
And does it work for KS patients?
Success rates are variable and certainly lower than for men with other causes of infertility, but they're absolutely not zero. It depends a lot on the individual, maybe whether they have mosaicism. But the possibility of finding sperm via microtease means that biological fatherhood, using IVF with ICSI, is now a realistic possibility for some men with KS. This has profoundly changed the outlook and counseling for newly diagnosed individuals, especially if sperm banking options are considered early.
That's incredible progress. Lastly, coming back to the neurocognitive side, those specific verbal and language challenges, what's the focus there now?
The key shift has been recognizing these not as signs of general low intelligence, but as specific language-based learning difficulties. This means the focus is squarely on early, targeted intervention.
Like the speech therapy you mentioned earlier.
Exactly. Early and consistent speech and language therapy, maybe starting in preschool or early elementary school, can significantly improve language comprehension, reading skills, and even executive functions. The goal is to provide the right support so that these specific cognitive differences don't unnecessarily limit their educational achievements or social integration. It's about maximizing their potential.
Okay, so this has been a really comprehensive look at the 47,000 XY blueprint. Let's try and summarize the biggest takeaways for everyone listening. Klinefelter syndrome, it's clearly much more than just a hormone issue.
Absolutely. It's a complex gene dosage disorder stemming from that extra X chromosome and the fact that X inactivation isn't perfect.
We saw how that overdose of specific escapee genes, like SHOX, directly causes features like tall stature.
Right. And how the condition carries significant systemic risks for type 2 diabetes, for heart issues like MVP, and especially that very high risk, 20 to 30 times higher, for those mediastinal germ cell tumors.
And the constant underlying feature is the male hypogonadism, the result of those damaged fibrotic tests, leading to that characteristic hormonal mix of low testosterone, high FSH, and often elevated estrogen.
And we can't forget perhaps the most fascinating molecular insight, that androgen receptor paradox.
Yeah, that was mind-bending.
The body's own attempt to compensate by silencing an X chromosome actually backfires, preferentially silencing the more sensitive androgen receptor allele.
Which leaves the individual less responsive to the already low levels of testosterone, making the hypogonadism functionally worse.
Exactly. It's a stunning example of epigenetic regulation having unintended negative consequences.
Which leads us perfectly into a final thought, something for you to maybe ponder after this deep dive. That mechanism, the preferential silencing of the better AR gene. It's striking case of the body's attempt to self-correct actually making things clinically worse.
It really makes you wonder, doesn't it? Beyond KS, how often in other genetic conditions, maybe even subtle variations, is the severity of the outcome shaped not just by the initial genetic change, but by the body's complex and sometimes flawed attempts to regulate or compensate for it through these epigenetic mechanisms?
Could understanding these compensatory errors be a new therapeutic avenue?
That's the hope. If we can understand why the body makes these perhaps detrimental epigenetic choices, maybe one day we could influence those processes directly, intervening at the level of gene regulation itself, rather than just managing the downstream consequences like hormone deficiency. It's a whole new way of thinking about personalized medicine.
A fascinating glimpse into the future, born from understanding the complexities of today. Thank you for diving deep with us.